We know that when dealing with a painful or dysfunctional hip, that movement and exercise is a critical part of the treatment and recovery process. But we are of course going to need to use and prescribe different exercises for different purposes. For example, we may need to prescribe some exercises to improve flexibility, or we may need to provide other exercises to build strength or endurance, and still other exercises to build or target joint control or stability. But with respect to our treatment, and certainly with respect to our exercise prescription for these patients, there is an order that we need to follow. And I think of this as sort of a treatment or movement hierarchy. It's like an order of operations that we would use in math. We need to do certain things in a certain order in order to make sure we are arriving at the desired result and the desired solution. And if we get the order of operations wrong, it's not going to give us the correct result that we're looking for. Now, with respect to musculoskeletal pain and injury, the treatment and movement hierarchy goes something like this. First, we need to build movement tolerance. This is the first and most fundamental step. The idea here is that we're trying to restore tolerance to basic fundamental joint motion. So think of it this way. If the body can't perform basic joint motions without hurting, we are going to have a pretty significant issue. If we take the hip, for example, if a hip can't flex, extend, abduct, adduct, and rotate without pain, that hip is either going to hurt all day or the body is going to be forced to compensate and find alternate movement patterns to get around the painful movements and painful positions. So with these patients who we classify as being movement sensitive, we are going to prescribe exercises aimed at reducing pain, to guide healing, and to regain tolerance to basic hip motions. Now these exercises are not the focus of this video, but I have reviewed these basic movement sequences in another video. And for anyone who is not familiar, I will post a link to that video in this description below. But what we do need to recognize is that treatment and exercise to desensitize the hip and restore movement tolerance is the first step in the hierarchy. But as important as reducing pain and sensitivity is, it's not going to be enough. We also need to build and restore full health and function of the hip. Or at least we want to work towards restoring as much health and function as possible. So the next phase in our treatment and movement hierarchy is going to be to build joint mobility and joint control. The idea here is that once motion is tolerated, we need to shift our focus towards restoring full function of the hip. It's these exercises we're going to discuss and review here. Now, I should point out here that when I say that motion is no longer limited by pain, I don't mean that the hip itself is not painful or that the patient is no longer experiencing symptoms. I mean that symptoms do not limit hip motion during our motion testing or with the exercises we're trying to prescribe and work the patient through. So as motion is tolerated, we start to increase the range of motion and intensity of the exercises to start to restore overall hip function. The way we need to think of this part of the hierarchy is that if we want to restore normal hip function, there are just certain basic fundamental things a hip needs to be able to do. For example, as we just said, a normal hip needs to be able to flex, extend, abduct, adduct, and rotate. And if these motions are limited, the hip is simply not going to work right. Again, this is similar to what we discussed with a movement-sensitive hip a moment ago. But the big difference here is that in that sense, the motions were limited by pain. But the limitations we're talking about here are not so much because the hip hurts, but more the result of mechanical or neurological compromise because of dysfunction of joint flexibility and or muscle or motor control. So in this video, we're going to go over the basic movement sequence routine that I use when dealing with hip pain patients. Now, an important point here is that we're going to use similar motions that we did with the pain tolerance routine. And remember, I will put a link to that video as well as an article in the description below. And hopefully this idea that we're using similar exercises makes sense because as we talked about, we are trying to target all of the basic fundamental motions of the hip. Now, we're going to do these same motions, but we're going to perform them in a pretty drastically different way. We're going to change not only how we are performing these exercises, but also our exercise programming in terms of sets, reps, and frequency. The real key shift here is that we're increasing the range of motion and intensity of muscle contraction and effort we're using. Again, to put this into context, when we're dealing with an acute hip or a hip in which motion is limited by pain, the goal was to move to tolerance. Their range of motion needs to be limited, and we're trying to clear the range. But as soon as the patient's symptoms improve and pain doesn't limit motion, we can start to work into the end range positions. Here the goal is to push into the end range, which will not only act to improve mobility, but it also increases muscle tension and challenges muscle control. We are essentially using the end range resistance to push against, to create a firmer, harder, more intense muscle contraction in these end range postures. So what I'm going to do in the rest of this video is to go over the exercises themselves. Then, as I typically do in these videos, I will circle back to review some of the key programming and progression criteria. Now, just as one last FYI, if you are a My Rehab Connection subscriber and you use our exercise software, you can of course find all of these exercises in the exercise library. You can search for each exercise by name in the exercise library itself, or you can find the entire exercise sequence in the exercise group section under the title Basic Hip Movement Sequence, Control Mobility Focus. Okay, now let's take a look at the exercises themselves. All right, so this is our supine hip rotation mobilization. We're going to simply start laying flat on our back. We can support our head with something if needed. From this position, I'm going to keep my legs resting on the floor. And from here, I'm going to rotate my legs outwards. This is hip external rotation. The legs are moving, but the motion is going to be really focused at the hips themselves. Legs are quiet, but they're moving out because of the action at the hip. We're going to hold this outward rotation 1 to 2 seconds. And then when I reverse the motion, now I'm going inwards. I want my toes pointing together. Legs are going inwards, knees are going inwards. But again, motion is happening at the hips themselves. I'm going to perform 10 slow, deliberate repetitions. As I'm rotating, I'm going to get to the end of the joint motion and really work, trying to pull that joint a little farther, feeling the muscles tense and contract around the hip itself. 10 slow, deliberate repetitions back and forth. Now, just as a side note, this exercise can be done bilaterally, meaning 2 legs at the same time. But in some instances, we may even want to perform it unilaterally, which simply means we can perform it just one side at a time. Back and forth, 10 slow, deliberate repetitions. So this is our supine hip abduction, adduction mobilization. So we're going to begin laying on our back. And in order to create some space, we're going to have the affected leg, or the leg we're targeting, is going to be flat. We do want the foot to be able to slide on the floor. Opposite leg is going to be bent, like I said, to create some space as we move the hip into adduction. So from this position, I'm going to pull my leg inward as far as I can. This is creating adduction of the hip. Hold 1 to 2 seconds. I'm going to then slide my leg outwards as far as I can into hip abduction or abduction. I'm going to perform these slow slides back and forth. Now remember, as I'm moving, we want to keep the motion isolated to the hip itself. As we move all the way in, or certainly as we move all the way out, there's going to be a tendency to want to create motion through the pelvis and the trunk. We want to try to minimize that from happening to keep the stimulus at the hip itself. Also, as we're moving, we want to fight for every last little inch and degree of motion possible. As I get to the outside, I should really feel the muscles on the lateral part of my hip tense and contract. We want to make sure these muscles are engaged and driving the motion. As I go inward, same thing. I may feel some stretch along the outside, but I should see or feel the adductor muscles on the inner part of the leg contract to drive the motion. 10 slow, deliberate repetitions back and forth. Remember, we want to be engaged. We don't want just to go through the motions. We want to really work the muscles, feel the joint working, feel the muscles contracting to drive and position the joint back and forth. Now, of course, we did talk about how we can train rotation from a supine position, and this really helps to train rotation with the hip being neutral relative to the trunk and the pelvis. But we also want to train rotation from a more flexed position just to make sure we're targeting the entire joint and the muscles around the joint. So instead of on our back, we can perform this from a quadruped, just basic hands and knees position. So I'm simply going to be hands and knees. I'm going to take the affected hip. I'm going to rotate my thigh and hip outwards. Here my foot is going to go away from me. This is going to create internal rotation of the hip. At the end of the motion, I'm really trying to squeeze. I'm trying to get this foot as far as possible to the outside. And as I do this, I should really feel the muscles tense along the side of the hip. I'm going to hold this 1 to 2 seconds, and then I'm going to bring my foot inward. Now here, of course, we're going to run into the leg, so we need to create space. Perhaps the easiest and most effective option is going to be just to bend the knee slightly, and then we can rotate that leg so our foot is going to go underneath our body towards the opposite leg. Again, as I get into this position, I get to the end of the motion, I'm going to really try to squeeze, really fight for every last little degree of motion that I can. Again, as I do this, I should feel the muscles stretch and pull and contract side and back of the hip. Hold 1 to 2 seconds, back to the outside, moving into hip internal rotation. Hold, squeeze the muscle, back the other way into external rotation, back and forth. Now, just as a side note, the other option in order to get some space, in order to kind of move into this motion, is we could also kind of extend the opposite leg, and then we can create some space that we can move under the opposite leg. So 2 options. Again, we're just rotating that hip back and forth. Now remember, when we're doing this, we want to make sure we're isolating motion to the hip. We need to really work to generate tension and motion at the hip itself. There is often a big tendency, because this hip is often limited, is that when we go to rotate our leg, we're going to want to twist and turn through our trunk and through our pelvis. And we want to point this out. We want to try to really minimize this as much as possible in order to keep the motion isolated at the hip itself. So again, going in, holding, feel that muscle squeeze 1 to 2 seconds, going outwards. Again, fight for every last little degree of motion we can. Feel the muscles work, feel that thigh rotate under your body. Slow, deliberate, 10 repetitions back and forth. To train hip flexion and extension, we're going to do so in a quadruped position. So again, I'm just basic hands and knees. Now from this position, I'm simply going to pull one thigh up towards my chest. This is hip flexion, of course. Hold 1 to 2 seconds, and then I'm going to bring my hip back. Thigh and leg go back up towards the ceiling, trying to create extension through the hip. Now again, as I pull forward, I want to try to pull that leg, pull that thigh as high up towards my chest as I can, but I do want to try to make sure the motion is staying isolated at the hip. Here, there's going to be a big tendency to twist through our body or even to flex or create a kind of a pelvic tilt through our lumbar spine. Again, we want to try to minimize that so the motion stays isolated to the hip itself. As I'm pulling my thigh forward, I'm really trying to feel the muscles contract deep into my hip, this hip flexor group right deep on the front of the leg here. Likewise, as I go backwards, I may feel some stretching in the front of the hip, but I would like to feel the muscles in terms of the back of the hip, the glute group, etc., really contract and pull that leg up towards the ceiling. So again, just back and forth, being very slow and deliberate, really trying to feel those muscles work. Visualize that hip moving into flexion and extension in the socket. 10 slow, deliberate repetitions. All right, so now that we've gone over the exercises and the program itself, let's go over some of the key programming and progression criteria. First, as I briefly mentioned when reviewing the exercises themselves, the key with these motions is to push into the end range. I refer to this as an end range squeeze. The concept here is that we're using the end of the joint range to push against. This allows us to contract harder. We're essentially creating a firmer isometric contraction at the end of the joint position or the end of the joint motion. But just to reiterate, this is assuming that the motion is tolerated. Remember, especially when transitioning from a pain tolerance phase to a control mobility phase, we need to ensure that the motion does not create pain and make sure the motion generates the appropriate feeling and sensation for the patient. If this isn't the case, you may need to consider regressing back to a pain tolerance perspective or a pain tolerance focus for another week or so. Now, patient education matters too. We want to make sure these patients and our clients are not just going through the motions. They need to be conscious, go slow, and be deliberate with each motion. You want to focus on feeling the appropriate muscles contract, and it can even be helpful to visualize the joint motion. This consciousness and deliberateness has far-reaching effects. When we do these things, we're not only affecting changes on a tissue level, but on a neurological level as well, especially with respect to control and coordination of joint movement, and even with respect to things like cortical maps and body representations within the brain itself. Now, as far as programming, the typical prescription is going to be to perform each of these movements for 10 slow, deliberate repetitions. And we're typically going to repeat this twice a day, at least initially. Now, as patients get better with range of motion and their control improves, we will often add in additional patient-specific strength or flexibility exercises. And when this is the case, we will often reduce the frequency of the program to once a day.